Good afternoon and good morning, everybody. This is Amanda Pierce-Kelly with the National Association of Community Health Centers. I'm the National Advocacy Director. I really appreciate everyone taking the time to join us today for a really important webinar looking into 2017, as you can see there, hopefully our first slide, and what this new landscape looks like and means for health centers. This is the start of what will be a series of advocacy and policy briefing webinars that we'll be hosting each month. Right now, things are evolving very quickly and therefore changing, and so we want to make sure that we provide you all the most up-to-date information and keep you informed of what those changes look like, and we'll get into that later. But again, just really excited to have everybody join us today. A couple of quick housekeeping items. The first thing is that the audio today is coming through your computer, hopefully. For those of you that are not accessing sound, hopefully you're seeing the slide and able to make that work so that you can hear us through your computer. The way that the system functions, that is the best way to access the information and to hear us speak during the discussion today. So you can use this slide to adjust your volume and access the discussion today. The next thing is that this webinar is being recorded. We want to make sure that for folks that are not able to join us live right now and or for those folks that want to be able to share this information coming out of the discussion today and the presentation, that we can make this available and accessible to folks on a regular basis. So you'll see here on the slide where you'll be able to access that recording. It'll be on the Campaign for America's Health Centers website. That's www.saveourchcs.org. You will also see a link to access on youtube.com, NAC Media. That is usually available within 24 to 48 hours. Give us a little bit of time. If you don't see it pretty immediately, feel free to always email us, and we are happy to give you access. We'll also make sure to put something out in the NAC Washington update, which is distributed weekly, so that folks can access the webinar that way. So the other housekeeping item is that we want to make sure that we hear from you. We want to take as many questions as we can, comments, and the best way to do that is to enter your question or your comments into the chat box. Given the number of people participating, which I'm thrilled to say we have a huge turnout today, the very best way to engage with you all is, again, through that chat box. So don't be shy. You can see the arrow there pointing to where you want to enter your question. You can direct that to an individual panelist or speaker, or you can address everyone. But either way, we will do our best to take up as many questions as we can throughout the webinar. We'll probably leave about 10 to 15 minutes right at the end to walk through as many of those as we can. So let's go ahead and get started. What we want to do today is give you guys a lay of the land. There's so much information and, frankly, misinformation flying around right now. You can't, every hour it seems to change. And what we want to do is use this time to share the latest facts. There are still many, many question marks, but today we really want to walk through what do we know? What does this look like? What is the lay of the land? We then want to lay out our plan and what our approach looks like and our strategy so that folks feel empowered and clear about the direction that we're going. And while there may remain many question marks about proposals and structure and even systemic change, the great news is that there are so many opportunities ahead of us. And as a program, we're so fortunate to have many friends and allies and deep support on both sides of the aisle and really every corner of the spectrum. And so part of the excitement today is to really discuss that part of the equation and that part of the discussion, which is where can we go and what opportunities exist? And when we work together, we know that we can be successful no matter what comes at us. So with that, we're going to take some time to go through those latest developments. We'll have some discussion about what is it when we talk about repeal and replace. We'll, again, discuss the NAC strategy and priority issues, particularly as it relates to Medicaid and health center funding. And then we'll have a final discussion there about what our messaging looks like, making the argument for health centers, and what specific advocacy action steps exist and what y'all should be doing coming out of this discussion in this webinar. So with that, I'm going to turn the controls over to my colleague, John Sawyer, who is our Director of Federal Affairs, to talk you through the next set of slides. I know he's joined by some colleagues as well. So, John?
today's webinar. We're pushing 4 digits in terms of the number of people who are on, and so we're really just grateful to each of you for taking some time out of your day. Obviously, where we wanted to start is to just go back through the election results. Obviously, this election was a big sea change in terms of control of some of the levers of power here in D.C., and we want to kind of emphasize a couple of points as we go through. Obviously, first, you see the Electoral College results there at the top from the presidential election going to President-elect Trump. We saw a number of states, primarily in the upper Midwest, that flipped this year from Democrat to Republican. We do note, of course, that the popular vote was won by Secretary Clinton, which is not to say, that the outcome of the election is in doubt, but I think it's to say that it was extremely close, and there is a real argument over what kind of mandate the new administration has coming in, and I think that the closeness of those results is also reflected very directly in what happened in Congress. And so what we saw in the Senate was a tightening of the margin. Same thing in the House. Democrats picked up a small handful of seats in both, meaning that while Republicans continue to have the majority, that it's a smaller majority going forward. And I think that the main point of that, a couple of key points in that have direct implications for health policy. Number one, as we'll talk about a little bit later in the PowerPoint, certain things in the Senate take 51 votes to pass, and certain things take 60 votes to pass. And so, obviously, you can see with the numbers there at 52-48 Republican, we'll be paying especially close attention to those things that can be done with just 51 votes under a process called budget reconciliation, which we'll talk more about shortly, because that's really what we anticipate is going to move on the fastest track. The second, and I think larger point about having tighter margins in the House and in the Senate is what that means is every member's vote is that much more important. At this point, if 3 Republican senators change their vote on any particular issue, you have a change in the outcome. And by the same token, it takes a smaller number of House members to really influence the outcome on any side. And so what that means is we want to talk about the key committees, we want to talk about the leadership, and we'll talk about that, I think, on the next slide. But even if your member is not in the leadership, even if they're not on the key committees, what this means is every member could really change the outcome of a debate. And so that's why our advocacy piece is so important. So to move on to who are some of the key players going to be in healthcare in 2017. And this is by no means an exhaustive list, either in the administration or in Congress, but we did want to highlight for you some of the key folks who we already know will be in decision-making roles next year. That starts at the top of the Health and Human Services Department. Congressman Tom Price of Georgia has been nominated to take over HHS, which of course oversees all federal health programs. He is currently the chair of the House Budget Committee. He's authored a bill to replace the Affordable Care Act and has a long track record with health care, not just from the policy side, but also in practice. He's an orthopedic surgeon who's practiced in a number of different settings in Georgia. And then at the head of the Centers for Medicare and Medicaid Services has been nominated Seema Verma, who is a Medicaid consultant, worked very, very closely with Vice President-elect Mike Pence in Indiana to develop their Medicaid expansion waiver, also known as Healthy Indiana Plan. I think both Congressman Price and Administrator nominee Verma are clear signals about the direction the new administration wants to take. Congressman Price is a vehement opponent of the Affordable Care Act, and Ms. Verma is very, very focused on Medicaid, probably the first CMS director that we've had in quite a long time who's a Medicaid person rather than a Medicare person. And so I think we're expecting a lot of changes on both of those issues. Just as noted here, we don't know currently who will be the next HRSA administrator, whether key positions that have been filled at the Office of Management and Budget, and then certainly some of the lower down the rung assistant secretaries at HHS, all things that we'll be updating as we go through these monthly webinars. Over to Congress for a minute, and obviously we're just highlighting some of a small group of folks who will be involved in these things. What I want to note here is less the individual people with whom we're working a lot of different relationships, and many of you, we have great advocates as key contacts in many of these districts, but to also make the point that these decisions about the future of healthcare and many of the debates next year will be happening within committees. And so just to talk about those committees for a moment, because it's important that every advocate know if their member is on a key committee and what that committee has jurisdiction over. House Energy and Commerce is probably the most comprehensively important committee to our folks and to health centers. That's because they have jurisdiction not only over the health centers program, but also over Medicaid itself, as well as 340B and a number of other public health programs. Also important is the House Ways and Means Committee, which oversees much of the Medicare program, as well as private insurance and tax issues. And then, of course, appropriations in both houses goes line by line into the funding for key programs. In the Senate, they divide things up a little differently, so the Medicaid and Medicare and insurance are all handled in the Finance Committee under Chairman Hatch. And then in the Health Committee, Health, Education, Labor, and Pensions, they really deal with more of the public health side of the ledger, including health centers, workforce, 340B. The key leadership in the House, Paul Ryan, as folks know, is the Speaker, and continuing on as Democratic leader is Nancy Pelosi. In the Senate, Senator Schumer from New York will be taking over as Democratic leader with the retirement of Senator Harry Reid of Nevada. And then Senator McConnell of Kentucky will continue as majority leader. So I think where we wanted to start is really with the future of the ACA. And I think given the result of and the outcome of the election, the larger question, and I think the larger frame for all health policy discussion this year and probably for years to come will be how does Congress both repeal and then equally important, how do they replace some of the key provisions of the ACA moving forward. And I think what we want to stress here is that there are more questions than answers about that right now. We wish we had all the answers, and I think you'll see this list of questions dwindle if you come on each monthly webinar with us over the next several months. But right now, questions as big as what's on and off the table in a potential repeal. We'll talk about this in a little bit more detail, but when people use the word repeal, we're actually talking about a smaller group of provisions from the ACA, not every single word. How long will that repeal be delayed? Because what's clear is that if repeal passes, it's not going to be implemented right away. But what happens in the meantime? That's also unclear. Even without changes to the law, people could see the writing on the wall and big changes could take place in the healthcare system. And then what does a replacement plan look like? There have been several options, and we'll talk about those. But then within that replacement plan, how do we ensure that there's a role for health centers? Beyond that, what of all of these things that are being discussed actually has the votes it needs to pass Congress and to pass into law? All of those questions and many more, I think, at this point are under discussion, unanswered, and anybody who tells you they have all those answers is probably selling you a bill of goods at this point. But these are the kinds of things that Congress and the administration are going to be wrestling with over the coming months. So just to dig in a little bit more and add a little nuance to this conversation about repeal and replace, I think what is more straightforward of those two is the current plan for what we're calling repeal. And as I said, there's a roadmap. Congress has passed a piece of legislation last year that really repealed some of the big pillars of the ACA, and the only thing that stopped that legislation from being implemented was President Obama's veto. So that is now the roadmap that they'll be using, probably on a relatively fast track, to pass effective repeal of some of the major provisions of the ACA. And what you can see there under that third bullet is some of those big pillars include a repeal of the Medicaid expansion, a repeal of the subsidies that have gone to help people purchase exchange coverage, a repeal of the individual and employer mandates that require people to purchase coverage, and then a repeal of some of the large tax provisions that really helped finance the ACA in the first place. There are other pieces in there, but the ACA itself had more than 500 provisions. What we're talking about here is 10 or 12, but they're really some of the pillars that hold up the entire law. And so we're going to be watching that. Part of the reason those provisions were the ones that were chosen are because those are things that can be done through what's called budget reconciliation. As I mentioned earlier, that procedural mechanism that requires you only need 51 votes, and therefore this can be done on a fast track. What's not clear is there is still big support for many things out of the ACA. In particular, the President-elect has talked about wanting to keep the exclusion on the prohibition on exclusion from insurance based on pre-existing conditions. He's talked about wanting to keep the provisions that allow individuals to stay on their parents' coverage up until they're 26. And so it's very unclear what can be kept and what can be repealed without really creating more or less chaos in some of the insurance markets and creating even more uncertainty. That's why that delay is something that's very much on the table right now. And there are also folks calling for replace to really happen at the same time as repeal. Importantly, the funding mechanism that set up mandatory funding for health centers is not eliminated in the current version of repeal. But importantly, and we'll talk about this a lot, that doesn't mean we don't still need to get the money. And we're going to be fighting, in midst all of this debate, another funding cliff, and we'll talk in much, much more detail about that later in the program. On the replace side, it's much more complicated, not only in terms of the healthcare system being much more complicated, but it's also much more complicated to pass legislation because in large part, many of the things that you would replace the ACA with require 60 votes in the Senate, meaning you would need a bipartisan coalition. Democrats have already indicated through Senator Schumer that they're not interested in, partaking in that, the replacement plan, and so that will become very, very divisive as well. That being said, there are several major plans. A few of them are actually introduced as legislation, and then some are introduced as more white papers, concept documents. Probably the most prominent among those is the House Republicans' plan issued earlier this year called A Better Way, and we'll talk in a little bit more detail coming up in the Medicaid section specifically about some of what that would propose. All of the plans, again, are much more focused on the changes in the coverage and insurance markets. They all contain structural reforms to Medicaid, for example, block grants or per capita allotments, and we'll explain that difference. They all point to the increased use of high-risk pools to care for sicker and poorer individuals. They all would include some kind of tax credit for individuals to purchase private coverage. And I think importantly, at this point in the process, none of those plans currently speak to the role that health centers would play in a new system. That doesn't mean we don't have support. That doesn't mean there isn't a role in this debate. But what it does mean is that these plans are largely focused on the coverage side of the equation, perhaps a little less on the access side, which is really where health centers come in. So I think that there is a lot of change afoot. It's important that we see the world in a way that we are ready for those changes and ready to advocate on behalf of our patients within that debate. But none of this is a foregone conclusion. It's not a fait accompli, and we really want to stress that going forward. Congress is messy. Healthcare policy in Congress is doubly messy. And this will get very, very tricky over the course of the next number of months with lots of twists and turns. That being said, we're very clear and feel very confident that even amidst that change, health centers are extremely well positioned. Why is that? Well, for starters, health centers truly are one of the few things in healthcare that both Democrats and Republicans agree on. We can tell a local story about what you're doing, about the impact that our services have had on patients, on community members, on people that actually members know, and in some cases members actually go to the health center for their care. There are health centers in almost every congressional district in the United States, and that's an enormous advantage for us because we get to take this large national problem and boil it down to a local impact and what the local implications are for a member. We also have a direct and clear track record of success in expanding access to care, in improving quality of care, and in lowering costs. And we have hard data that shows what the impact of health centers has been and what our value is, whether that's to patients, to communities, to the overall healthcare system, and certainly when it comes to those economic impact and the cost savings, the impact to the taxpayer. I also think it's really important, and one way that we differentiate ourselves is that we fight harder because we speak on behalf of the patients we serve. You've seen a lot of groups come out over the last week or two speaking to the potential implications of repeal of the ACA, changes to Medicaid, and what it means for the bottom line. And obviously that's an important consideration for us, but I think the way that health centers and health center advocates will differentiate ourselves is that we speak on behalf of the patients and what these changes will mean for them and how we need to make sure that they are not injured through, and that access is actually expanded for them through some of these changes. I just want to focus a little bit more and step back on messaging and how do we talk about health centers. We've already gotten into some of this a little bit in terms of why we're so well positioned, but we're going to talk later in the PowerPoint about specific messages on each of the big two issues that we're focused on today, Medicaid and funding. But even beyond that, there's kind of a set of big picture messaging that we think is really important. And that starts with the very, very basics. Everyone needs a place to go for care, period. And health centers are a local solution to a national challenge, which is access to primary care. This is something that no matter where you're from, urban, rural, West Coast, East Coast, or right there in the middle, people really understand what it means to have a hard time accessing primary care. I think importantly, and this was our theme all last year, is health centers are innovators. We put patients at the center of our care, we listen to our consumers and our communities, and we develop innovative solutions to very difficult problems. Health centers deliver, as we've said, value and impact for the health system and the taxpayer. So you can see some of the numbers there. We're up over 25 million patients now. The integrated care that health centers provide. I've been saying a lot lately, health centers is one of the only places in the country you can go to your doctor's office and there's a dentist in the room next door and a behavioral health provider down the hall to give you integrated comprehensive care all under one roof. Cost savings, we have great new data about the 24% lower total cost in Medicaid for Medicaid patients who are seen at a health center. And of course, you can see there some of the numbers on economic impact, not only the jobs that we create directly, but then all the economic activity that comes out of the health center sector. I think it's also important to note as we think about big picture messaging for health centers that we're really on the front lines of some of the most challenging health crises going on in the country right now, whether that's stepping in when the VA was struggling to provide access to primary care for veterans to give them a place to go for care. Whether it's the opioid epidemic, where 271 health centers have now been funded to take on that challenge very directly. Whether it's Zika, where yesterday direct funding from the federal government went to health centers and PCAs in Puerto Rico and the territories to take on the Zika threat directly. We really are being called on by policymakers on every different challenge and have risen to those challenges on those front lines. And then I think that's to the last point. For more than 50 years, health centers have delivered stability for patients, even as the healthcare system has changed around them. As the health center director said to me yesterday, we were here before the ACA, we were here during implementation of the ACA, and we're going to be here through what's next because what we do is so important for the patients we serve. But I think it's important, and this is going to be one of our key messages going in, the targeted investment in health centers and a strong Medicaid program that really recognizes the role of health centers are the pillars. They're the two key pillars that the entire system of care rests on. Both of those are up for debate this year, and we need to be very clear about the importance of both Medicaid and federal investment going forward. So with that, we're going to talk about the legislative priority areas. As Amanda alluded to earlier, we're going to focus first on Medicaid and health center grants, really the two biggest priority issues, and then we're going to talk later in later podcasts maybe not yet, webinars about additional issues, workforce, 340B. I put up this slide to really illustrate how we're thinking about prioritization of these issues. We all know how important workforce and the 340B program are to health centers. Those are high priority issues. They're enormously important to what works and how health centers work. But really at this point, Medicaid and health center grants have to be the highest priority. Like we said, those are the two pillars that hold up the whole system. There is unique policy in both that affects health centers. NAC is, and our advocates and our partners at the PCAs and at networks are central players in those debates, and so that's what we'll be focusing on today. We're going to start with Medicaid. I'm going to turn it over to my colleague Jen Taylor to really go through the Medicaid section. We'll cover some background, some key facts, talk about what's on the table in 2017, and then really go through our ask and our strongest arguments going forward.
Hi, everyone. This is Jen Taylor from the Federal Affairs Department here at NAC, and I really appreciate you taking the time to join us today. I'm going to try to go through this Medicaid section pretty quickly just so we make sure we have plenty of time for discussion, because I know you guys have a lot of questions, and we also still have a lot to talk about on the health center funding and grant side of things. But I think what we wanted to highlight is, you know, we knew entering this year, regardless of outcome in the election, we would be spending a lot of time talking about our upcoming primary care funding cliff. We knew we had 2 years from the last time we fixed it, and we were gearing up for that discussion again this year. I think one thing that has changed since the election is we anticipate a much bigger focus on Medicaid alongside talking about our health center grant funding this year. So I'm going to walk through, you know, what we do know right now in terms of the most likely outlook for Medicaid in 2017 and highlight where we think there are potential challenges, and also talk through where we can work together to meet those challenges. I think, you know, before we dive in too deeply, I just wanted to do a really quick slide to remind everyone some basics on Medicaid and how it works currently. We know that Medicaid is a joint federal and state program that's the single largest source of health coverage in the country, currently covering more than 70 million people. It currently works as an entitlement program, which means certain groups must be covered, and if you fall into one of those categories, you are entitled to the benefits of the program. ACA, as you know, was the most recent large-scale legislative effort to change or add to Medicaid. In this instance, it expanded Medicaid to everyone below 138% of the federal poverty level. In a subsequent Supreme Court decision, that expansion was made optional for states, and as a result, 31 states plus the District of Columbia have expanded their Medicaid programs in some capacity, but leaving 19 states that have not adopted a Medicaid expansion at this time. Each state has their own Medicaid plan, but they can receive exceptions with waivers. Those waivers need approval from the federal government, and some of you may be very familiar with the process of working with CMS to cover additional populations, change eligibility, benefits, and payments. But we also know CMS had their own sort of guidelines about which waivers may be approved, and I think we'll talk a little bit more today about whether or not that's going to be changing in the coming administration. The thing, you know, we always want to highlight for people, we cannot overstate how important Medicaid is to health centers. Medicaid and health centers really work hand in hand to provide coverage and access to our patients. 49% of our health center patients are covered by Medicaid, and it makes up 44% of health center revenue across the country. That means roughly 12 million people in the country, that's 1 in 6 of every Medicaid beneficiaries, get their patients at a health center. And as you know, in addition to the importance of Medicaid largely for our patients, health centers also have a very specific FQHC PPS, that's our prospective payment system, which allows for adequate payment for our services. And so we're going to be talking a little bit today both about the importance of Medicaid in general and the coverage it provides for our patients, but also specifically its unique role for health centers. I won't go into too much detail, and I think most of you on the call are very familiar with PPS, but we should be clear that not everyone understands that health centers have very specific federal protections and Medicaid language. While that's not been the target of any conversations, those specific protections would certainly be impacted both by any potential legislative changes to the program in general and also potentially through the waiver process in a coming administration. And so our FQHC prescriptive payment system we know covers a bundle of Medicaid services we provide at FQHCs. We talk about it as providing adequate and predictable rates based on the cost of providing care and as the comprehensive services that we provide. States and health centers can negotiate for alternatives and working through alternative payment methodologies, but they must use PPS as the floor, which means it really allows health centers and states to experiment with new ways of paying for this care that still provides for the stability of knowing that health centers are going to be able to keep their doors in and provide coverage to Medicaid patients. One thing that I want to highlight is that PPS is subject to state waiver, and we've had some questions about this in the past. PPS can be waived. In the current administration, we did not see any waivers approved that waived PPS, but I think, again, as we move toward a perspective in CMS that might be more inclined to have states having more control, we're going to need to continue to monitor how that plays out. And I think that leads us really to looking at what we consider to be sort of three big challenges and potential changes for Medicaid that are on the table in 2017. And I'm going to talk through each one of these in turn. First, to discuss the repeal of the Affordable Care Act and its implications on repealing Medicaid expansion. Then talking a little bit about the potential for having structural financial changes to Medicaid in terms of block grants or per capita cap allotments. And then also thinking through both Congress and CMS's inclination to have increased flexibility for state programs. First up, and I think this is the most timely, we'll be talking about the repeal of Medicaid expansion. And I think John already kind of walked you through what we're facing in terms of the repeal and its impact on Medicaid expansion. This can be done very quickly, as John mentioned, potentially as quickly as January or February of this year, should the stars align for those who would like to repeal portions of the Affordable Care Act. Based on what we know now, we believe that a repeal of Medicaid expansion is likely to be included in that effort, though that is not a guarantee. That's based on the fact that what we've seen in terms of the most recent reconciliation bill that was vetoed by the President did include a repeal of Medicaid expansion. It did also include a sunset date for that, which was in that bill December 31st of 2017, so they left themselves about a year and a half in terms of a delay period. It was likely that a repeal of Medicaid expansion would also be subject to some sort of delay, as John mentioned, but we really don't know what that looks like, and we don't know what that would mean for the roughly 22 million people who have gained coverage throughout the Affordable Care Act, through the Affordable Care Act broadly, roughly half of them through Medicaid expansion. Obviously, NAC understands the implications of this for health centers, particularly in the 32 states that have expanded their Medicaid programs. We have taken the position that there should be no repeal of the Affordable Care Act and no repeal of Medicaid expansion without a plan in place to ensure continuous coverage for the folks who gained coverage through the Affordable Care Act. We know, we've heard people in expansion states, obviously this is of huge concern, and we very much understand that. We expect to continue to talk with you in the coming weeks about how to message any potential threats on the Medicaid expansion. But I also want to mention today that we know sort of the second follow-up to the Medicaid expansion might seem even scarier to folks on this call. And I want to set the tone before we dive into this that we do have, tools to work from. There's a lot of education to do here, but as John mentioned, nothing is set in stone yet about what might happen with the structure of Medicaid moving ahead. It's certainly not guaranteed we will repeal the expansion, though it is on a faster track to do so. I would say even more challenging in the long-term stability to Medicaid would be looking at a block grant or a per capita cap, but it's also a much heavier lift to do so legislatively, and so we've got a long road ahead of us before we were to get to this point. The reason we're flagging it is while a block grant or a per capita cap would certainly not have to be included in any sort of replacement plan moving ahead, it's something that has been discussed. It's something that is included in a better way, as John mentioned, the House Republicans plan that we think in a large extent is a roadmap for what might happen next. There are also other members of Congress, including potentially the new incoming HHS Secretary, Mr. Price, along with members of the Senate, Mr. Hatch and Cassidy, all of whom have legislative proposals to in some way, shape, or form, either block grants or provide per capita cap allotments to the program. And so we think that there's certainly potential that this will be a path that Congress will pursue. Quickly, without getting into too much detail, I think people on this phone probably know, but a block grant would cap the federal dollars to the entire state, and a per capita cap allotment would cap those dollars by person. There's challenges potentially to both. The goal of either of those things is to try to limit federal expenditure on Medicaid. Certainly, I think members of Congress that propose these plans would argue that it incentivizes the states to be more efficient with their dollars. Certainly, I think there is also a worry that comes with that in order to provide coverage with fewer dollars, states may be put in a position of having to eliminate benefits, limit eligibility, or cut provider payments. There's only so many ways you can account for a limited number of dollars coming into the state. We know Congress has explored these options before, and we've listed a couple of times this has come up. There will be a lot to learn from those discussions, and we know, so far we've successfully navigated these challenges for the program. There's also going to be some things that are different this year, and we're going to have to work together to figure out how best to face those challenges. The last piece I wanted to mention is we've kind of talked about it a little bit here today, but there certainly is, regardless of what happens legislatively, whether or not Medicaid expansion is repealed, whether or not they pursue a block grant or per capita cap structure, we know that there is a goal of both the new administration and the Congress to give states more flexibility and more control over Medicaid programs. We've seen that both in legislative proposals like A Better Way, and we've heard that stated both from the President and in the incoming, President-elect, and in the incoming CMS administrator. So we expect that this will be a strategy and an ultimate goal of those who will be making decisions about the Medicaid program next year. And we do want to highlight that that absolutely could constitute a threat to FQHC protections when they are not protected specifically in state law. Waivers that allow for much more flexibility and don't protect PPS as the floor, or legislative proposals that remove all federal safeguards around financing of the program absolutely would leave FQHCs vulnerable, and that's something that we're going to work hard to both educate our members of Congress about and to try to prevent any potential damage.
I just want to interject one thing here, and it's a plug for a future webinar, but as you can already hear, federal and state policy are very, very closely connected, especially within Medicaid. And so we will be talking in more depth on future webinars about state-specific actions, strategies, and outlook that really affect health centers. Dawn McKinney and our State Affairs team are on the phone with primary care associations at least once a month on a national call, which happened yesterday with more than 100 people on it. So we're paying a close attention to this from both the federal legislative but also the state perspective, and we'll get into that more in future webinars. Okay, back to Jen.
Thanks, John. And actually, I just have a little bit here before we wrap up. I just wanted to sort of leave you right now with where our kind of asks are regarding Medicaid, and I think these are going to change. This is going to be an iterative process in the coming year. We're going to work together to figure out how best, I think, to protect both the larger Medicaid program, and which is, as we discussed, foundational to FQHCs and a critical source of coverage for our patients. We know it's dependable, we know it's affordable, and we're going to be working to protect that moving ahead, and also to be talking about how we both protect and strengthen health centers' unique role within the Medicaid system. We know, again, we've talked a little bit today, and we'll continue to talk in the coming months about how health centers and Medicaid work hand in hand, and I think that's particularly going to be an area of advocacy for us to focus in on with our members of Congress who may not realize how unique our role is. Not everyone understands our specific PPS payment system, and there's going to be a real opportunity for education for us there. The last thing I wanted to leave you with on this Medicaid piece, you'll see some of these arguments are going to come up several times today and are familiar to what John already discussed in terms of big picture messaging, but really our job here is going to continue to remind both members of Congress and the administration that health centers are a key part of any healthcare solution. We have a great story to tell. I think John highlighted some of that messaging. We're going to provide you additional resources at the end of this webinar and in the coming weeks that will help you make these messages clear. But health centers are going to be key to anything that Congress or the administration, has in mind moving ahead. We are, and we have to really make that connection to Medicaid. What I would say is interesting in my experience, we have a lot of health center champions, which is a credit to your good work over the last 50 years in building up those champions, but many of them do not understand the connection we have to Medicaid, and we might have somebody in one room who says, I love health centers and I'll do anything to support them, and then the next conversation is really threatening the existence of Medicaid and may not realize how closely connected those two things are. So again, I think we have a big educational opportunity to talk about who we are and who we serve, and to tell both the big picture story about about health centers, and specifically how health centers and Medicaid are a success story together. We know Medicaid patients and FQHCs have lower total costs of care. Again, we're going to help build some of these arguments into the resources we're providing. We're making things like customizable templates, one-pagers, educational information on PPS, and hopefully that will help you make these connections for your members of Congress, both in the importance of the big picture Medicaid and in preserving our unique role and payment. And with that, I'm going to hand it back over to John, who's going to talk through on the health center grants front.
Thanks, Jen. And thanks for those of you on the phone who are patient with the background noise. We're on a fairly main drag here in D.C., so the occasional fire truck and ambulance goes by. Apologies for that. I think Jen really covered why Medicaid has risen to occupy a place right alongside actual health center funding as our top priorities this year. So I want to dig in a little bit because this may be a little bit more familiar to folks. We haven't had to fight the Medicaid fights over the last number of years, but we have successfully fought over the many years on funding, and we're going to have another set of challenges up this year. So again, just to start with a little bit of background, the Section 330 Health Center Grant Program that supports almost all of your health centers really at this point is formed by two different sources of funding that combine to form the one 330 grant program. And so those two sources of funding are the Health Centers Fund, which we also call mandatory funding. That was funding first created by the Affordable Care Act and then extended for 2 years thanks to our advocacy efforts across the board in 2015. And that funding at $3.6 billion a year is set to expire again at the end of this year if Congress doesn't take action to extend it. That's actually required spending, and so it has to go forward unless Congress steps in and changes the law. What you may be more familiar with is what's known as appropriations or discretionary spending, which is the annual process that Congress uses to determine the amount of funding for grant programs like health centers. Before the ACA, this was the only way that the Health Centers program was funded. Then we have the mandatory funding program that's been added in with the ACA. And so currently that annual appropriation or the discretionary amount is at $1.5 billion a year. So what does that look like laid out in a chart? So this chart shows the funding levels for health centers going back to fiscal year 11, just after passage of the ACA. And what you can see there is the blue piece of the chart is our discretionary funding, the red, the mandatory funding, which then was extended for 2 years, again in 2015 on a bipartisan basis, and expires at the end of this fiscal year, September 30th of 2017. Again, just to emphasize, if Congress does not take action to extend that funding further, 70% of health center funds will cease to exist, will go away, and the program will have to reconstitute itself with a much, much smaller amount of funds. This would, there's no question that if that cliff is allowed to hit, it would affect every community health center, not just those who've gotten a new access point over the last number of years, though many of you have, but much of those dollars has gone into base adjustments, it's gone into service expansions, and with that large of a cut, there's no way that every health center would not be impacted. Just an analysis of this that came out of the Department of Health and Human Services in 2015. We're working on, by the way, getting the updated figures for 2017. But they estimated that 2,200 sites would have closed were this allowed to happen. Over 7 million patients would have lost their access to care at health centers, and over 57,000 jobs would have been lost had this funding been allowed to go away. As I say, we imagine these numbers are even larger now. We're working on getting that made public because we know, I think, that some analysis is being done of that, but we anticipate an even larger impact were this cliff to hit now, since more of these resources have been invested. Not only would this, be a disastrous cut to health centers, but it would really reverse a longer trend that goes further back than this chart shows, back to the beginning of the George W. Bush administration and even into the first Clinton administration, which would quickly reverse really more than 2 decades of investment in health centers on a bipartisan basis. And so just again to sort of hit the key facts, even if the ACA repeal were to pass in 2017, we still need to address this funding cliff. Without action, as we've said, that happens on October 1st of next year. At the same time, alongside the health centers funding, all funding for the National Health Service Corps, as well as the Teaching Health Centers GME program, is set to expire at the same time. I'll talk a little bit more about other programs that are set to expire and how we're all trying to band together to really get this all addressed in one fell swoop. Again, no one knows how HRSA would implement such a large cut, but what we have to assume in the absence of that, and we'll have tools to help you calculate this, is that each center would have a loss of 70% of grant funds, because that's the total loss. We will be seeking a fix, and I think this is important, on any and every quote-unquote vehicle, which is to say piece of legislation that's moving this year. And I think what's important to know is that obviously, as you heard from Jen, and I think in the setup of the PowerPoint, many of the things that are moving this year will contain things we don't like or things that are potentially controversial. And so we're going to have to judge that on a case-by-case basis, but there's also going to be very few bites at the apple to get this fix done. So just again, just to highlight, I think I've said this a number of times already, but right now the cliff will happen if Congress does not act by September 30th. There are limited vehicles, as we said, and almost everything is controversial. Importantly, as we noted, a number of other really critical programs, the Children's Health Insurance Program being probably the largest, most well-known, and most popular, have the same expiration date this year for their funding, September 30th, the end of the fiscal year. And so we're working really hard to coordinate at the national level with groups that are working on each of those big issues. There are probably 20 programs all told whose funding expires at the same time, and it's really important that we stay coordinated, not only to push for solutions together, but to avoid stepping on each other's toes or pitting each other, one program against another. The last point I'll make, I think, in terms of the outlook is that health centers, as we've noted, are very, very bipartisan. But much of the debate over health care this year is going to be highly divisive. And so it's going to be something for us to navigate is how do we advance the cause of health centers within or alongside other very highly divisive debates. I won't take a lot of time with this because I think we've made a lot of these points already, but it's important to understand that there are some differences in terms of the cliff fix that we got in 2015 and the effort this time around. I think most importantly, there's now a bipartisan precedent for members of Congress, a vast majority of members of Congress to have voted in favor of health center funding, mandatory funding. That's the biggest advantage I think we have. Pre-2015, we had only had Democrats who had voted for this kind of funding, and that was directly tied to the ACA. I think it's really understood differently now, and that's important. The biggest challenge, of course, is the cost. Just to stay where we are, we need a minimum of $3.6 billion a year, and that doesn't get into any new funds, no new access points, no service expansions, no base adjustments, and so As you'll see, we're talking about a kind of a two-part ask at this point. And this, as Jen said, will be iterative over time as we get a clearer picture of what's coming. But our first ask is really to sustain health center funding at current service levels to make sure that there's stability of access through any healthcare transition. Secondly is to build in some targeted new investments, really to address the increased demand for health center services and to help drive system transformation. Those are the kinds of things like the service expansions, quality improvement, and other grants that have gone out over the number of years that have really driven our whole system forward in terms of being more integrated and higher quality. So again, just to go through some of the arguments here that we'll be using, it all starts back on that slide about big picture messaging. We are a key part of the healthcare solution. We want to be part of the healthcare solution. We need to be part of the healthcare solution. And we bring that local economic impact, cost savings, quality improvement, all of those pieces is really where we have to start with every argument. Second argument is really about the implications of inaction. With a 70% cut to funding, we've already gone through what the numbers would be in terms of the millions of people who would lose access to care, tens of thousands on jobs, and more than a couple thousand site closures for health centers. We need to translate those national numbers down into local numbers, and when we get to the resources page, we'll talk about some of the things we're working on to get that up. And then lastly, last on that point, again, that the investment under both Bush and Obama, both administrations, would quickly be undone. The progress that's been made would quickly be reversed. And so, I think then turning towards the positive, really talking about how the federal investment is the key to the care and business model of health centers. It allows us to provide the comprehensive services we provide. It allows us to be incentivized to go into underserved communities where there are no other providers, and it allows us to be open to all patients regardless of ability to pay. I think that leads us to the last point, which is that in an uncertain environment like this one, especially when people may be seeing changes in their coverage or even losing their coverage, health centers are the key to stability and continuity in the healthcare system. As Congress considers all of these changes, we're really going to be urging that they stabilize and strengthen the investment in health centers going forward. So we have covered quite a lot of information up to this point. Hopefully that has been helpful. We wanted to really boil this down because one thing we're encouraging folks to do is to invite their members out to their health centers. Amanda and her team are going to go into those steps. But, we wanted to boil this down to what do I say to my member if I'm sitting across the table from them tomorrow? And I think it's really 3 points. One, health centers are one of the few things in the healthcare policy that both parties agree on. We need to remind them of that. We need to underscore that. And given that, we really need to make the point that health centers need to be part of solutions to these healthcare crises. Second, that Medicaid, a strong Medicaid program, and federal investment through health center grants are the 2 pillars of our success over the years. They're the 2 things together that have held up this system of care and made it the success that it is, both in delivering access to care to patients, but also in delivering that value, that cost savings to the healthcare system and the cost savings to taxpayers. And then I think it's important to convey that we are concerned about repealing the Affordable Care Act without a clear plan to replace it, without a clear plan that ensures access to care and coverage for the patients we serve. And so the request to Congress really is to work with us to both minimize uncertainty for health centers from a business perspective, but also enact solutions that work for our patients. So with that, we're going to talk about what you can do, some key advocacy steps to take now to really start the ball rolling and get ready for the year ahead. So I'm going to turn it over now to Amanda.
Thanks, John. And while we're dealing with the technology, just so I can start advancing the slides here, and this is the fun part, guys. This is where we talk about, all right, what are the specific activities that you should be working on? You have all the information, you've got the updates, you're empowered and informed. And so now, as informed advocates, what is it that you should be doing? And there are some really easy action steps that we really encourage and want you guys to be moving forward on between now and we'll say middle to end of January. And at that stage, we'll have a brand new presentation and a new webinar to give you guys the latest updates. So the first thing is, of course, staying committed to being informed and engaged. And the reason that we start there is that it's very difficult to be an effective advocate if you don't have the information. And so we are working very, very hard to make sure that we keep you up to speed, which we've talked about. You can see there that this was the first of what will be monthly webinars, and the dates there at the bottom for those that will be upcoming, January 18th, February 22nd, March 21st. That isn't to say that we're not going to be sending out communications to keep you up to speed in between those dates, but that will be an opportunity to really get into the weeds around, okay, what does this look like? What is the next set of activities that we should be focused on from an advocacy perspective? If you haven't done so already, absolutely sign up to be a health center advocate. You can do so by joining the Campaign for America's Health Centers. The web address is there. You can join right on the homepage, or you can text. For those of you that want to receive text alerts, you can text HC Advocate to 52886. Those are very important tools to staying engaged and up to speed when there is a need to be in contact with Congress or a new set of action steps. That's the way that we communicate that to our Health Center Advocacy Network. So just save those dates for the upcoming webinars and make sure you join the network as a Health Center Advocate so that we have a very strong and unified voice for the Health Centers program and that you have the absolute latest information. The next is really getting a handle on what these issues look like at your health center. There's two parts to telling the health center story. One is the personal story. What does this mean to you? What does your health center mean to you? How did you get involved? Why is it important to you? What do you witness every day on the ground there? And what does it mean to your community? And those stories are extremely important, the personal side. But the other side of that coin is telling the story using data and numbers. It makes your advocacy that much stronger and more clear. And so being able and preparing now to be able to share that side of the story is absolutely critical. And we've just gone through what this looks like in the context of health center grant funding and what the primary care funding cliff looks like. And so now is really the time to do that analysis. What would it look like to experience a 70% reduction in your grant funding? On the Medicaid side, you really just want to be prepared with the basics. How much of your health center revenue comes from Medicaid? How many of your patients that you're currently serving fit into different levels of federal poverty level brackets and eligibility groups? And so it isn't that you need to get extremely complicated with this, but I think having a handle on what that data and what those numbers look like so that as you're having these conversations with your members of Congress, other stakeholders and opinion leaders, you really can paint the most accurate and clear picture possible about the potential implications. There are a couple of different tools that we'll be putting out here very soon, and again, you'll be able to access those. You'll see the actual web address here on a later slide, but you'll be able to access those again on the Campaign for America's Health Centers website. One is an updated version of what we call the Cliff Estimator tool. That's something that we put together that allows, on a health center basis, to estimate what that funding cliff would look like for your health center in a variety of different ways. And we are also working on a template for a Medicaid impact statement. So stay tuned on those. But moral of the story on this one and the action step is really to get a handle on the data analysis for both of these areas for your health center. Thirdly, and John talked about this, I really cannot stress this enough, taking the time right now, in the next 4 weeks, we'll say, maybe not even that long, but as soon as possible to get meetings scheduled in person with your members of Congress while they are at home and in the district, ideally at your health center. The reason for that is the more opportunity we have for them to understand the value of the role you play to your patients and your community, to have a fresh memory and picture in their brain about how important health centers are, there's nothing more valuable. Educating them about what you're doing well, how you do serve as a solution, again, that vital role to your patients in the community, but also what's at stake. I think right now we've been using this term a lot. it isn't so much about pushing proposals, it's more about setting the table. It's reminding them about how important you are and letting them see with their own eyes. The other thing that I would say is that there are many of you, over 60 as I recall, who have brand new members of Congress. And those are folks we really need to prioritize. These are folks that hopefully have some understanding of health centers, but we cannot take that for granted. And so for those individuals who are arriving in Washington, D.C. as a freshman member of Congress, the best thing that you can do is find a way to get them out to your health center over the next few weeks before they arrive in Washington so that they have that foundational understanding of who you are, what you do, why you are so important, and how you can be a part of the solution as many of these issues continue to unfold and as proposals are put together. You can find information about how to host effective meetings with your members of Congress and other elected officials on the Campaign for America's Health Centers website. There are many, many resources available, and of course we will be providing talking points to make sure that you're all comfortable and armed with the right bullets in terms of how to have some of these conversations. But remember, as advocates, you really are the experts when you're talking about your health center, and the important thing is just to work hard at getting those meetings lined up as quickly as possible. The last piece, and this is, I'm not sure, I actually might put this at the very top of the list, is about building advocacy capacity, and there are a few different reasons for that. We really have to get our house in order when it comes to advocacy in terms of the number of advocates we have engaged, the commitment to act and respond and engage on an ongoing basis. And that's not just for federal fights. That's not just for, communicating and advocating with your members of Congress. There are going to be many, many demands at the state and even the local level. And so the more capacity we have when it comes to advocacy, the better equipped we will be and the more effective we will be as those requests and challenges and demands come through. And so when we talk about building advocacy capacity, there's one program that NAC has really put a lot of energy into building. That's our Advocacy Centers of Excellence program, the ACE program. Under that program, you'll find very clearly framed steps for how to achieve various levels of excellence when it comes to advocacy. The first tier of excellence, which is our bronze level, really establishes that foundation across your health center staff, your board, establishing an advocacy plan and protocol and metrics so that you know how you're doing and you can have goals, just like we do with every other element of operations within the health center world. But that's really going to begin the process of creating a culture of advocacy at the health center, which will be so critical as we move into the next stage of this initiative, which will really be the engagement portion. As you move up in those tiers, it really focuses on not just having the tools and the foundation, but how people are engaging and getting involved and staying involved. So I would really encourage folks to think about what can we do, what can you do at your health center, work with your primary care association. We are very grateful to have wonderful partners across every single state who are working with us on this program because they recognize, as we do, that the demands at the state capitol will also require excellent advocacy and ongoing advocacy. So again, making sure that you're prioritizing efforts to build advocacy capacity at your health center, using the Advocacy Centers of Excellence program, and working with us directly and certainly your primary care association. And the last thing that I will say, outside of just prioritizing the building of advocacy capacity, is that there's going to be a period of time here that will move very, very quickly. As we get into the new year, certain things are going to happen, as quick as we can snap our fingers. But the long haul here is it's going to be 18 months, maybe 2 years. And so from an advocacy perspective, I just want to remind folks that you need to stay committed and be prepared for the marathon. It's not a sprint. And so again, pointing to that capacity element, now is the time to be building so that we can be prepared and be effective and successful as we take on that marathon. And I know we can be. We've proven it over and over and over again, but it requires everybody working together and stepping up, not just, signing up to be an advocate, but choosing to act repetitively as requested. So the last couple pieces here, and then I think we're going to switch gears and start taking some questions. We do want to just point you all to a number of different resources that we've put together for you. Everything from talking points to one-pagers, templates in terms of how to work with the media and local partners, state and congressional district maps, and finally, toolkits, advocacy toolkits. You can find these resources on the Save Our CHC's website. That's the Campaign for America's Health Center's website. We've dedicated an entire section just for this purpose. It's makethecase.cfm. If you are still in need of resources and support, you don't find it on this website, you are always welcome to email us directly. You've got 2 different email addresses there to contact NAC Federal Affairs or our grassroots advocacy team. Really, we're here to help you guys. We want to be as responsive as possible. So again, if you see that something is missing or you have a question, please don't be shy about making that request and being in touch with us directly. So I will just say that advocacy is going to be key. Everything that we do going forward is going to depend on the strength, the commitment, and the engagement of our health center advocates. And it's not just about health center leadership. For those of you that are joining us as CEOs and within the C-suite, you have a very important role to play. Those of you that are board members, you have a very important role to play in setting the expectation, the tone, and the culture at your health center so that every single one of the staff there, the entirety of the board, all of your community partners, really everyone that touches the health center is getting involved. So I would encourage you all to think creatively about how you can really bring as many folks as possible into the fold. All of you are so skilled and talented at creating partnerships in the community, often through the lens of operations and you know, clinical medical. Well, it's no different with advocacy. Sometimes it's relying on those same partnerships and relationships, but asking them to step up on behalf of the health center because they too have a stake in this, and reminding them of that and having those dialogues. So again, don't hesitate to reach out to us on the advocacy team if you would like help. We are available to work with you on a one-on-one basis, provide that technical assistance and training. Grassroots@nac.org is the best way to be in touch with us, nac.com. But let's go ahead. Here's our last slide here. Just a reminder on the next set of webinars. Again, these will be monthly, but so you can save the date and keep those handy. And let's switch gears here and take some questions.
Great. Well, we have a lot of questions here in the chat box, and just a reminder, if you do have a question, please put it in the chat box, and we'll try to get to it as quickly as possible. But we'll start with a question about advocacy. What is the best way to schedule visits with members of Congress for folks who are not in the D.C. area and maybe just getting started?
So I'm going to take a stab at that, and then John and Jen, if you guys want to chime in. Actually, it's in your favor right now that you're not in the D.C. area because if they are not already home, will be returning home very quickly. And so the best thing to do for those of you who want to reach out to your congressman is to contact their district office. It never hurts to sort of work both, where you're communicating with D.C.-based schedulers and district-based schedulers. But often it's as simple as putting in a phone call and an email and making that request and making the invitation. I think the more flexibility you can offer in terms of when you might be available for the congressperson to get out to the health center, if you can work around their schedule, that's ideal. But the point is, they're looking for opportunities to get out around their district, and it's really no different for members of the Senate. You just need to look at where the closest office is and work with them to try to identify a date and an opportunity to get them out there. But I think anytime you're working with congressional folks, flexibility is key. If you're able to say, you know, we want to extend the invitation, is there a day or a time or an occasion that works for them? That is ideal. It's harder when you've got a target. Anything to add, John or Jen?
I think the only thing I'd add, Amanda, is we've gotten the question from a number of folks. I have a new member of Congress, and so how am I supposed to get in touch with them? They haven't even set up their office yet. And I think that there's generally two things you can try that usually will work between one or the other. So one is to reach out directly to the campaign. Up until they take office, the campaign staffs will still at least have a skeleton crew there and will be working on kind of scheduling and helping that newly elected member get scheduled. The other thing is to reach out to the current office holder. So we got this question from Nevada the other day. Senator Reid is retiring. Senator Cortez Masto is the newly elected senator. If you can't get in touch with her campaign directly, Senator Reid's office should have a place to point you. And so it's the same principle. You may just have to do a little bit more calling around while they're getting their operation up and running.
And I've been reminded, I've had a nice note from one of our key advocates, Dave Brown from Michigan, who reminds us, rightly so, that the goal really is to get your members of Congress out to the health center. That's number one. But I would also stress, as David indicates, that congressional staff has a very, very important role to play as well. So if you're not able to get a commitment, first be persistent, don't let them off the hook easily. But it's not a bad thing to get congressional staff out to the health center. Make sure that you're working with them and developing those relationships as well, because frankly the staff is the direct line to the member of Congress. And so the relationships that you're able to forge on that side of things are equally important and successful in the context of our advocacy work.
Great. Well, I have another question here about advocacy efforts around the Affordable Care Act, and can NAC provide any guidance on responding to grassroots efforts from other organizations specifically designed to defend the ACA?
So, hi, it's John. I'll jump in there. Absolutely. I think the best way to do that is, I think, on a case-by-case basis. One thing we are always suggesting, I think, to advocates in the field is if you get an alert from another organization, if you want some input on, you hear about another bill or an advocacy campaign that's happening, shoot that over to us directly. Either of the email addresses that were on the earlier slide, federalaffairs@nac.org or grassroots@nac.org, because we'll give you our take. Everybody can make their own decisions about how exactly they engage in each of those campaigns. But if you want to say, how does this shape up with our messaging? Do you think the timing of this is right? How would you suggest we carry this message forward? We're always happy to engage in that conversation with you. And I think the flip side of that is the request that if you do hear from us and you do get an advocacy alert from Amanda, which is something we certainly anticipate a lot over the coming year, we don't do that unless we know that it's going to have an impact and that it's going to be serious. And so when we call on you, we really ask that you take that time, that you send that note, that you pick up the phone and make that call. But if you want to, you have another group that's asking you to take action, you want to vet that through us, we're absolutely here to sort of walk you through with that.
Great. And here's a question a little bit about sort of weighing priorities. We've got one person saying for their health center, the viability of the Medicaid program is really important, and it is probably more important for them than the health center grant. Can you speak a little bit to the importance of fighting both fights and making sure that both are priorities?
This is Jen. I'm happy to jump in, and John or Amanda, please feel free to add to anything I say. I think this is a question we've gotten already some, and we're going to continue to get. I think we totally understand, given the nature of health centers and the fact that each health center is unique, that for some people making arguments about the importance of Medicaid is going to be stronger and more accurate to their health center story than it is to be working on the funding side, and vice versa. I think that's why John laid out some good talking points, really highlighting how both pieces are foundational to health centers, and we plan on linking those arguments as we discuss, as we advocate in the coming year. But we absolutely want folks to really hone in on the piece that is also best for their own story. That's why we're going to have some of these customizable templates and materials. We're going to encourage you to take a look at those and see what helps you tell the strongest story for your patients, for your employees, and your community. And we think it's great to highlight that. We'll have some, broad messaging, and we'll continue to push that out in the coming months and up and through our Policy and Issues Forum here in March, when we know many of you will be joining us here in D.C. and meeting with their members of Congress. But we always encourage you really to hone in on the pieces that are most effective for your health center. Nobody knows your health center better than you, and it will all help us tell the collective story of the importance of funding health centers in the coming year.
I think the only thing I'd add to that is I think that's exactly right, and you have to tell the story that is most relevant, most accurate, and most timely to your health center. We definitely are speaking of these from the national and I think from the level of almost every state as co-equal priority one, because when you look at the numbers as they average out, it's very unlikely that the whole program could stay up with a big hit to one or the other. The only other point I think I would make is work with us to make sure if you're going into a particular member's office that your message is tailored to that member. Because, for instance, if you're going in to speak to the chairman of the Appropriations Committee and you're speaking mostly about Medicaid, as we've discussed in an earlier slide, that's not really under their jurisdiction, and they'll say, I hear you, that sounds important, but I'm really focused on this funding side. If you want to go in and talk about the grant to the chairman of the Finance Committee, work with us because we're going to need there to be a Medicaid message in there as well. And so I think just, again, feel free to reach out. There's no question too small. We've heard it all before, and so we would love and are happy to work with each of you. If you're going into a particular member's office, we're happy to strategize with you based on their committee, based on kind of where they've been positioned, of what to put ahead of what, and how to really frame the entire issue.
Great, thank you. So here's a question particularly about health center funding. Given the new political environment and longstanding bipartisan support for health centers, in your opinion, what's the likelihood that there will be no action taken come September 2017, or is there still too much time to know?
I think it's a great question, and like we said, I think there are some differences from the last time we did this. I think the bipartisan vote that we got in 2015 is a real asset to us going forward, but I think if folks have paid some attention to Congress over the last number of years, it's difficult to bank on them doing their job effectively, and unfortunately, I think the way that the funding is set up, inaction results in a cut. It takes action and it takes money in order to avert that cut. And so we are optimistic from the standpoint of the support that we have. There's no one out there pushing actively against health centers to be funded, but that being said, it's a real uphill battle to fund something that's in the billions of dollars in this kind of environment where it's still very, very divisive up there. I think the new administration for many folks is kind of an X factor. We don't know where they'll come out on some of these issues. We certainly reached out a lot during the campaign. We're reaching out to the transition. We're in touch. But, these issues are a little bit down the totem pole from those top-line issues, and we're really going to need support from across the aisle in Congress to take the lead on this. So we are going to be pushing. We have heard encouraging things, I think, so far in terms of people on the Hill really understanding in a way that they didn't last time what a big issue this is and that it's something that needs to be addressed. But getting through all the details of that, we very well could be up there towards the last minute.
Great, thank you. And I've got several questions from folks about sort of the legal do's and don'ts in advocacy and what they're able to do and not do at their health centers. And I'm going to put a link in the chat box in just a minute with some resources for that. But can you speak specifically to advocating for Medicaid expansion and or the ACA, and how that may or may not cross a line to the appearance of partisanship?
It's a really good question. So the first and most important thing is that we are nonpartisan. You cannot express any kind of partisanship. The tricky thing a little bit with the ACA is that there have been times historically where it has an element of polarization to it and perceived partisanship, but I think it's never an issue for a health center to advocate on behalf of their patients, and I think that's the tact you want to take. And so speaking to the importance of coverage, of continuity to care, of stability, and as it relates to the Affordable Care Act, I think going back to some of the messaging and the discussion that John and Jen spoke to earlier, and that is that as it relates to repeal, it is unwise and very concerning to be truly considering repeal without any true plan for replacement. And John and Jen, feel free to chime in. But in terms of just the legal boundaries, the big one, as I said, is we cannot ever be partisan. We are nonpartisan, legally bound. So just be cautious and thoughtful on that. The other thing is that anytime you're doing any kind of advocacy work, you cannot do those things with grant dollars, meaning it cannot be supported by any federal funding through the grant. That being said, health centers are very fortunate to have a very diverse revenue stream, and so typically that is not an issue. If anyone has any additional questions or wants to get into details or weeds on that, please reach out to us. We're happy to respond. The other last piece, just from a legal perspective, is that there's a big difference between advocacy and education. And a lot of what we're talking about now, quite frankly, is education. And what that looks like is telling the health center story, talking about what's at stake, talking about what you do well. You're not really at this stage pushing a particular proposal or specific legislative action. And so that keeps you in bounds on the education side versus the lobbying side, which is where the regulations get a little bit stiffer. So again, it's a longer conversation. In fact, we can and should and probably will dedicate an entire webinar just to that. But look for the resources that Alex is linking to in the interest of time here, and I want to take at least one more question. And as I said, if you've got questions beyond what we just covered, please reach out to us directly. We're happy to help, and we've got a lot of great supporting materials to assist.
Great. So here's a question about the replace package. This person asked, if the replace takes 60 votes, and this is where Medicaid changes would likely happen, is it accurate to say that block granting Medicaid would also take 60 votes?
That's a terrific question. The answer is we don't know exactly because it depends. The process through which it's determined what can be subject to reconciliation, meaning 51 votes, or what can be what is requiring 60 votes, is something that happens kind of on a case-by-case basis. And so the conventional wisdom is that a large replace plan that gets into policy change, that gets into a broad array of different proposals, is the kind of thing that would rise to the level of needing 60 votes. If a Medicaid reform proposal was put on the table standalone, it's likely that because that has a significant budgetary impact, that's the yardstick that Congress uses. Is it a budget piece or is it a policy piece? If it's just a budget piece, they allow it to be done with that 51 vote threshold. So those tests have not been taken yet because there's not a bill to either block grant or change Medicaid to a per capita cap that's on the table. That would also, the other important thing to note, again, this is getting into the weeds of procedure a little bit, but if you want to use budget reconciliation and have that 51 vote threshold, you can only do that once a year on a policy issue. And so they're going to actually have 2 bites at the apple next year because they actually didn't use that tool this year, so they're going to use this year's tool early next year, and that's the repeal. But then it's very unclear what they're going to do with the second bite next year. There's competing priorities. There's certainly the health pieces and the replace idea, the Medicaid pieces, but then other priorities like tax reform and changes to the tax code. So a lot of that is very uncertain. I wish I had clearer answers for you. It's absolutely a great question. It's one we started asking on November 9th, if not before, and it's something that we're going to be paying very, very close attention to.
Great, thank you. And it looks like we have time for maybe one more question. I've got one here about the 340B program. Can you speak to how the 340B program is included in health center, in policy changes affecting health centers?
Sorry, Alex, you cut out for a second. Could you say it one more time?
Sorry, yeah, can you guys speak to the 340B program and how that may be included in any policy changes affecting health centers?
So we absolutely can, and I think that's a good plug for a future webinar. As you can see on the slide that's up right now, we are going to go in more depth on 340B in the January 18th webinar. I think just to give a quick sense of that, and I want to highlight Michaela Keller from our team here who covers 340B. We do expect there to be debate over 340B in the year ahead. We do expect, I would say, large fights on 340B between the primary users of 340B being large hospital systems and the primary, I wouldn't say opponents of the program itself, but entities that are interested in changes to 340B, which is the manufacturers. We're in contact and coordination with all sides of that debate, and I think the good news is when most people look at health centers on any part of that debate, they look at us as the people who are using 340B right. The important piece is that we need to keep using 340B right and, staying in compliance with all of the 340B statute, regulations, grant guidance, the works, but we will get into a lot more depth, I think, with that issue on the next webinar.
Great. Well, we are running out of time here, folks, and it's been a long one, but I think well worthwhile. Just some thank yous. You've heard from John and Jen and myself, but there are a lot of folks on our team who spent a lot of time to put together what you saw today in terms of the slides. Alex Harris, Elizabeth Kwasnick, and Dorian Wanzer on the advocacy team, Alyssa Shinto, Michaela Keller, Abby Pinkley, and again, John and Jen on the federal affairs team, and our leadership. We are all pretty much working around the clock to make sure we are getting you as much information as we can, providing you the play-by-play and clear activities and direction around what we can do to be best positioned, even more so than we already are, to take advantage of all the opportunities that are coming and be nimble enough to respond to whatever challenges are put in front of us. So thank you again so much for joining us today. We will look very forward to speaking with you again on the next webinar. You have our contact information. The slides and the recording will be available again on the Campaign for America's Health Center website. Don't be quiet and shy. We love hearing from you, and we want to work with you to support your advocacy and make sure that you're informed on every moment. So thanks again. Happy holidays, everybody, and we'll look forward to talking to you again real soon. Take care.